So, in this lipid session, what I'm going to talk to you today about is another aspect of lipid management, that is the omega-3 fatty acids, whether it has any role in atherosclerotic risk reduction. Yes or no, there have been controversies regarding the omega-3 fatty acids. We are still not very clear whether really it is helpful or no. So, throwing some light on some of the recent data associated with omega-3 fatty acids. So we all know that statins have proved their role. Dr. Unnikrishnan just gave a wonderful talk on it. Statins have proved itself in terms of LDL reduction, and they have proved that coronary risk reduction is there when we are using statin to a great extent. However, there are some group of patients, especially patients with diabetes and metabolic disorders, who in spite of being on statins, we know that still have this residual risk of increased CVD there in them. And therefore, it prompts us to look at some of the other parameters of lipids, primarily HDL and triglycerides, and whether the reduction of HDL and triglycerides plays a role in reducing this residual risk. So hypertriglyceridemia is one of the area which is being looked after for a number of years. Hypertriglyceridemia per se represents the accumulation of proatherogenic lipoproteins in the plasma, mainly other components like triglycerides-rich lipoproteins and TRL remnants. They have shown an increased association of atherosclerotic vascular diseases, and typically we treat this hypertriglyceridemia with statins and fibrates, and lastly with the omega-3 fatty acids. There have been enough trials which have been done which have not been really successful, especially even after showing a reduction of triglycerides, they have not shown an enough reduction of CVD per se. If you look at ACCORD with fenofibrate, if you look at Origin with omega-3 fatty acids versus placebo, or improve of lately with ezetimibe, which showed some amount of reduction. But primarily these are trials where the kind of cohort they used and the kind of population they studied maybe were not very ideal. If you look at one of the trial called JELIS, which is a trial done with EPA, one of the omega-3 fatty acids versus placebo, it did show a significant 19% risk reduction in terms of coronary vascular diseases. But the dosage that was used here was around 1.8 grams, which is slightly more than what was used in the other prior trials. So primarily the older trials which have been done till now, either they did not enroll patients which were right for those trials. Primarily they did not enroll patients with very high triglycerides. They used patients mainly with triglycerides only less than 200, or they primarily used omega-3 fatty acid at a substandard dosages. Most of the trials like Origin Omega had a dosage of 1 grams, which is not the recommended dose, and primarily the dose needed is more than 4 grams. So what are omega-3 fatty acids? We all know they are primarily ones with the double bond, covalent bond, which is the main difference in there. Alpha-linoleic acid is the primary constituent of it, which undergoes transformation and is then modified to EPA and DHA, that is eicosapentaenoic and hexanoic acid. It has roles in multiple areas. Primarily, naturally, they are found in certain flax seeds oil, soybean oils, and certain plants. And when they are modified, the EPA and DHA are mainly found in fish oils and in fish, which is the natural source of this. So there are various properties of these omega-3 fatty acids which makes them, properties which makes them prone to improve the cardiovascular risk per se. They have been shown to improve the HDL cholesterol levels. They have shown to increase the arrhythmia thresholds. They have shown some endothelium-dependent vasodilatation. Plaque stability is one of the features associated with omega-3 fatty acids. They have shown to decrease triglycerides level to a certain extent. Inflammatory markers like interleukin-6 have been found to be reduced. Some amount of blood pressure and heart rate variation has been shown. Blood pressure, mainly in clinical trials, they have shown a reduction of around 5 millimeters systolic to 3 millimeters diastolic reduction. Heart rate difference of around 3 to 3.6 beats per minute has been shown a reduction in most of the trials done with omega-3 fatty acids. Per se, the omega-3 fatty acids, that is the EPA and DHA, are found together in the fish oils and in fish. But as they are synthetically produced and they are separately used, the properties of EPA and DHA we know that they have certain properties which are different from each other. If you see the triglyceride reduction, there is a reduction of around 12 to 25% seen with EPA and DHA both. And especially when you're using it in patients where the baseline triglyceride levels are high, you can see even a reduction of up to 45%. DHA per se works only on increasing the HDL, on HDL. EPA does not have any effect on that. The small dense LDL particles conversion to the less atherogenic one is done by DHA. Some amount of blood pressure reduction, as I showed you, improvement in endothelial functions, decrease in heart rate, platelet activations has been found to be there. A decrease of oxidative stress is associated with both these EPA and DHA, which has been seen. So the primary mechanism of action is thought to be different of why they are helpful. But mainly, if you see between the two, the DHA is found to be mainly converting or acting into the neuronal cell membrane, improving the fluidity there, and thereby improving, increasing the cholesterol-rich protein there, which is essential for the neuronal membrane. While the EPA, which is the more active one or which is the more studied one, mainly it intercalates into the neuronal membrane, and it makes an environment with, in the membrane which is rich in cholesterol-rich proteins there, and thereby it is thought to also cause scavenging of free radicals and thereby having its antioxidant properties. Apart from that, there are various other areas. It is known to improve endothelial dysfunction. It is known to decrease the oxidative stress, mainly by improving the nitric oxide ratio, improving the nitric oxide bioavailability. It has shown improvement in terms of plaque growth, reducing the plaque growth. It has improvement in terms of reducing the interleukin 10. It decreases the interleukin 6. The lipo and C-reactive proteins have found to have some amount of effect by EPA and DHA. Unstable plaque, where the plaque stability is something which EPA increases, and EPA also decreases the plaque volume, arterial stiffness, thrombosis, and platelet activation. So these are various factors or various properties of EPA and DHA, because of which it is thought to have some amount of beneficial effects seen in terms of cardiovascular risk reduction. So let us look at some of the important trials which have come up in the last few years with omega-3 fatty acid and where we stand with it. So ASCEND was one of the studies. It's a phase 4 double-blind randomized 2x2 factorial prevention study. A huge study done with 15,400 adult patients with diabetes but no past history of CVD. It had it is a 2x2 factorial because it also studied 100 milligrams of aspirin given daily to this set of patients to look whether aspirin is beneficial as a primary prevention. And one arm had omega-3 fatty acids using at a dose of 1 gram with placebo. The primary efficacy outcome looking at first cardiovascular event of MI, stroke or ischemic attack or death from any vascular cause. It also looked at primary safety outcome for any major bleeding event and a secondary outcome also looking at GI tract cancer. Baseline 63 years of age, most of them were male, 94% had type 2 diabetes with an HbA1c of 7.2 on an average, with hypertensive 75% already on statins and a BMI of 31. The primary endpoint, it showed around 8.9% in the omega-3 fatty acid group versus 9.2 in the placebo group with an hazard ratio of 0.87 to 0.97. Clinically not significant and did not show a benefit in the omega-3 fatty acid group compared to the placebo group. So it was a longest duration placebo-controlled randomized trial which showed that omega-3 fatty acid did not have a positive effect or did not show improvement or risk reduction primarily in patients with diabetes and with a risk factor. Then came another design study called VITAL study, which was a still larger study done on 25,800 healthy patients. The difference was the cohort here. They were not all diabetics, only some group of them were diabetic, but they are primarily patients with more than 50 years of age and women more than 55 years of age, looking more at a primary cohort. Again, it had a 2 factorial design. It also studied vitamin D, an effect of vitamin D on cardiovascular risk reduction and cancer. And one arm had omega-3 fatty acid, again at a dose of 1 grams per day. Baseline again, 67 years of age, 50% were male. Only 13% had type 2 diabetes here. Looking at primary endpoint, composite of myocardial infarction, stroke or death from any CV cause. Again, the hazard ratio between the two was not significant. 0.92, a reduction of only 7 to 8% in the omega-3 fatty acid arm. Only 2.98% showed the difference versus 3.23 in placebo. Individually, when you look at the hazard ratios of MACE, total myocardial infarction, stroke, CV death, cancer or in cancer death, all ratios were per se between 0.9 to 1 and clinically were not significant. Again, VITAL study did not show benefit in terms of omega-3 fatty acids. So both the studies, though well-designed, large randomized controlled trials, did not meet their primary endpoints and did not demonstrate safety for omega-3 fatty acids, did not demonstrate benefits of omega-3 fatty acid, but they did show the safety of omega-3 fatty acids. The adverse events related to bleeding or any other adverse events were not seen here. The REDUCE-IT is the latest study, which was a large study done, published very recently. It's a study which is again double-blind, multi-center, randomized placebo-controlled trial done on around 8,000 patients approximately. All were statin-treated patients, more than 45 years of age, with coronary vascular disease, or with more than 50 years with diabetes. The baseline triglyceride levels were between 150 to 490, between up to 500 here, and LDL levels were 41 to 100. Now the LDL levels of 41 to 100 on statin made sure that these patients were well controlled in terms of their LDL cholesterol, and so an additional reduction of triglycerides with omega-3 fatty acids maybe or some other factor might help to reduce the coronary event here. The dosage difference here was it used 2 grams eicosapentaenoyl ethyl, which is a variant of EPA, a more purified variant of the EPA, used twice daily up to 4 grams per day, and looked at median follow-up of 4.9 years and compared it with placebo. The placebo used here was a mineral oil placebo given to patients. Looking at primary efficacy endpoints of CV death, non-fatal infarction, non-fatal stroke, and looking at key secondary endpoints of composite of CV death, non-fatal MI, and non-fatal stroke. More than 19,000 patients were screened here, out of which 8,100 were randomized. Adults more than 45 years with established CVD or more than 50 years with diabetes were included. As I told you, fasting TG levels more than 150 and less than 500 were here, but 10% of the patients in this still had a triglyceride levels of less than 150 also, which were included here. And LDL of more than 40 to less than 100. Patients with liver disease and pancreatitis and heart failure were per se excluded. The baseline characteristics more or less were similar here. The patients were more or less all on, as I told you, were on high intensity statins, most of them, and with high risk CV disease. Looking at the biomarkers after 1 year of therapy, there was a reduction of triglycerides by around 19%, a reduction of non-HDL by 13%, LDL cholesterol went up here, but when they compared it with placebo, the difference was around -6. That means the patients in the omega-3 fatty arms had a lesser increase of LDL as compared to placebo. HDL difference of 6.3, and a major advantage in terms of reduction of C-reactive proteins was seen here at the end of 1 year. There was almost 358, almost 300 times increase in the level of EPA from baseline, which clearly showed the increase as a level of EPA or which was given to these patients here. The primary endpoint showed a reduction of CV death, MI, stroke, and revascularization, which was surprising here. A hazard ratio of 0.75, a reduction of 25% seen here. The key secondary endpoints of CV death, MI, and stroke was also significantly reduced by around 26%. The interesting part also was that the graphs, the Kaplan-Meier graphs, if you see, the time of separation happened almost after 2 years of therapy. So which clearly showed that the benefit that came was not only because of the decrease of triglycerides at the end of 1 year, but something else which was working in this patients, and it started separating after 1.5 to 2 years. So eicosapentaenoyl ethyl, which was used here, was favored here for primary as well as secondary prevention cohorts. In both the groups, men and women showed equal benefits here. Patients with a triglycerides of more than 200, less than 200, more than 150, less than 150, all showed a similar benefit in terms of primary as well as secondary endpoints, which showed that the benefit was received equally well in all the groups. As I showed you, the CV death reduction was seen here by 20%. Another advantage was the effect on coronary revascularization, which was not there in any other CV trials done earlier with omega-3 fatty acids or with triglyceride reducing agents, but which was seen here in the reduced IT trial. In terms of safety results, it showed clearly benefit. There was no major adverse events seen. Mainly which were worried about was the bleeding related disorders. There was slightly increased incidence of bleeding disorders, but that was not of a very high numbers in the omega-3 fatty acid groups. Apart from that, diarrhea, peripheral edema was seen at slightly more extent in the omega-3 fatty acid group. Increased incidences of atrial fibrillation was seen in the omega-3 fatty acid group again, but overall a 28% reduction in non-fatal stroke, and the atrial fibrillation numbers were not very high. It had some amount of limitations here in this study. 6.4% of patients were on ezetimibe. This ezetimibe group was not significant. Ezetimibe was not a drug which was very potent, considered very potent at the time when the study was started, but the newer studies recently have shown ezetimibe coming back and showing some amount of benefits. PCSK9 inhibitors were not used here. There was a difference of around LDL of 5 milligrams per deciliter between the two groups, but that doesn't seem to be the reason for benefit, because the number 5 milligrams is very, very small to show this amount of benefit. So compared with placebo, at a dose of 4 grams per day, it showed a 20% reduction for death due to CV cause, a 31% reduction of MI, 28% reduction for non-fatal stroke, a lower incidence of side effects like atrial fibrillation or flutter. It worked in all triglyceride levels from 135 to 500 and showed a benefit in terms of primary as well as secondary cohort. Whether these results can be extrapolated to other groups or no, or whether omega-3 fatty acids really will show such kind of benefit still for it. There are some upcoming trials coming up next year. There is a strength trial which is going to come up in 2020. Again, it's a trial which is done for secondary prevention of CVD using a dose of 4 grams per day, expected in 2020. There is another trial called RESPECT, which is also expected in 2022. It is using a dose of 1.8 grams, done again on huge amount of patients. So these trials will again tell us whether the trials of the results of reduced IT are one-off results, or whether really omega-3 fatty acids are going to show positive benefits in terms of this. There is another trial called Prominent, which is again being done on individuals more than on 10,000 patients approximately, to look at again CVD risk reduction in patients with diabetes here. And these are all patients on high intensity statins with an LDL of less than 70, with a triglycerides of 200 to 500. Now there is again one more question which comes up, and because the FDA has clearly shown or been telling in US that consumption of fish and fish oil is beneficial for the heart, what happened is that huge amount of people started consuming fish in large amounts, thinking that it is the best thing to use to supplement omega-3 fatty acids. So when a research or study was done to look at the commercial preparations or the over-the-counter preparations which we get with for omega-3 fatty acid versus the prescribed drugs for omega-3 fatty acid, there is a huge difference between the two. The commercial drugs, the over-the-counter preparations, per se, they do not undergo any purification studies or any efficacy studies, because they are now classified under the food supplement criteria. The dosage that it has is very, very less of EPA and DHA, and a person has to take at least 10 capsules a day for this to have the required dosage of EPA and DHA. And the purification process and the manufacturing process these drugs undergo, the EPA is a molecule which gets actually destroyed because of the oxidation, and it is not, it does not maintain its potency. So clearly it showed that adequate dosage is not there in these preparations which are available. So to conclude, patients with hypertriglyceridemia do remain at an increased risk for atherothrombotic events and inflammations. The data and clinical studies clearly show the efficacy and safety and appropriate dosage of triglyceride lowering therapy is needed in order to achieve the desired benefit. SN and VITAL were the large randomized controlled trials, but failed to show demonstrate benefit with low dose omega-3 fatty acids. Mainly the dosage, maybe the use that were there or the kind of population they incorporated were not the right ones. The reduced IT at a dose of 4 grams per day of ecasopentyl did show significant reduced CV events compared to placebo, and ongoing studies like strength and prominent might give us more clear picture whether really omega-3 fatty acids plays a role in terms of ASCVD risk reduction or no. Thank you.